Okay, so you did your homework. You watched season 1, episode 2 of Grey's Anatomy on Netflix, and then you came on over to YouTube and you came with me, hit the like button and the subscribe, and you came on over here so that you and I can do case studies. Remember, we're doing case studies all the time because we're trying to get ready for the NGN Next Generation NCLEX exam. Some of you were rush trying to take the old test before the new test, and you didn't do too well. I know I had somebody in my class who was not ready to take this test and they failed it, and then my heart goes out to him. But guess what? Get up, get back on that pony and ride it, baby, to the next test, because I got you on this Next Generation NCLEX exam. So let's look at what we have to do, because the Next Generation NCLEX exam is going to measure clinical judgment. Clinical judgment is 6 parts, right? You know, the first part is recognize the cues. The second part is analyze the cues. The next part is prioritize the hypothesis. Then you got to generate solutions, take action, and evaluate outcomes. Now, if you'll notice, the first 3 are thinking, strategizing, really like critical thinking type of activities, right? And then the next 3 are, what did you do about it? You got to do something. So here we go. Let's introduce you to this case study. If you did your homework and you watched season 1, episode 2 of Grey's Anatomy on Netflix, then you know, and I gotta say something to y'all, quit stealing Netflix, please. Y'all need to pay for the stuff. Quit stealing everybody's codes, okay? Because, you know, it's a really good forum for great TV. So stop it. But back to the case study, not to the thieves. Okay, here we go. 25-year-old female, unconscious after a sexual assault. Trauma. Her Glasgow scale was 6. Oh yeah, you better know your Glasgow scale for this test. Her blood pressure was 80/60. Her exam reveals a blunt head trauma, unequal breath sounds, unilateral pupil dilation on the right side. And she is a rape victim with a thin frame, probably about 100 pounds, 5'2" in stature. And she had shredded fingers as evidence that she tried to fight back, right? The patient is for an x-ray, a CT scan. You can see them doing log rolling right on the show if you watched it. There's a Zoll monitor being used for transport and a ventilator planned because she's unconscious. I mean, that's like, you know, rocket science. No, not quite. It's easy as it could get, right? If you're unconscious, of course, you need a vent. Now, she's going to the operating room for brain surgery. Brain surgery is successful, and during the surgery, they noted that the bowel was perforated, so they repaired that as well. There was evidence found in her bowel that she actually fought so hard that she was able to bite the male organ or his penis off, and that we'll get to later. Patient to the ICU for close monitoring on a ventilator. Now, during her post-op recovery, her ICP did increase. She did need a burr hole, and a skull flap was left to relieve the pressure. And we heard on the show that the next 72 hours were critical. All right, let's dig in, shall we? Your first thing we're gonna do, the very first thing we're gonna do is step number 1 of clinical judgment, which is on the Next Generation NCLEX exam. It's recognizing the cues. Now, I told you to start with one big thing. I said, look at your case study. And if you can, make sure when you look at the case study, you recognize which system it probably has the most to do with. And you would agree that this system that this case study has to do with is neuro. I mean, we got a lot of brain stuff going on. We got some unconscious stuff going on. We got some pupil dilation stuff going on. So this is a neuro patient for the most part. We got some GI stuff going in there as well, but you know, it's a neuro patient. And you might remember me telling you that every time you figure out what system it is, go back to your basics about that system. Now, if you forgot the basics about the system, Don't worry. Remember, on this YouTube channel, there are playlists with all the systems. So if you forgot neuro, there's a playlist with everything neuro. If you forgot your cardio, there's a playlist with everything cardio. If you forgot GI, there's a playlist with everything GI. You always have to go to the playlist, just like there's a playlist for Dr. Chelly's case studies, my wonderful case studies using Grey's Anatomy. So if we look at this patient, we can say that for the most part, they're neuro. That's the system we've identified. We've got to remember that the answers probably are going to have a lot to do with the neuro system. And when we look at this, we have to go piece by piece, word by word, and pull out the meat and the potatoes. That's how you recognize cues. Now, we're not going to analyze them yet. We're just going to recognize cues. Let's do it together. Remember, age is always a cue. She's 25 years old. Female versus male is always a cue. Common sense. This unconscious issue is a cue. And I bet you're over there thinking, definitely sexual assault is a cue, because we have sexual assault nurses that are going to need to be called to this case. And then, of course, we're looking at our Glasgow score, our blood pressure. Even this word, blunt head trauma, is a big deal. Unequal breath sounds, unilateral pupil dilation. The fact that she was raped will play a role in our care. The fact that she has a thin frame should make you think of some things. The fact that she fought back and had shredded fingers is a big deal. X-rays, CAT scans, log rolling, and then the fact that she's on a ventilator. Okay, so these are all ways of recognizing the cues. Like, you just have to pull out words that will play a role in how you approach this patient. What would you want to know as a nurse taking care of this patient? Okay, so as we go a little bit further, we are already going to the OR for brain surgery. The surgery was successful, but there was a bowel perforation. OMG, that's going to be a big deal. And then the patient went to ICU for close monitoring on the vent during the post-op period. And post-op period is extremely important to NCLEX. During the post-op recovery period, ICP did go up, burr hole was made, skull flap left to relieve pressure. Now let's have a little fun analyzing, because all we did was recognize cues. Basically circling the key issues that we are honing in on as we try to take care of this patient. When we analyze cues, this is where your critical thinking comes into play. Because if you look at everything that I circled and you start thinking, how do we analyze these cues? Let's look at the 25-year-old first. Remember what I taught you about age. It's a number, so it's huge. Every number on this case, every number in the case study is something you should isolate and think, what do you have to know about it? If you look at that age, it's childbearing age. So she is at risk of being pregnant from this rape. She might have been pregnant already. As a matter of fact, I teach all of you that if you are working in the emergency room, that anyone of childbearing age, which is from 12 to 51, needs a pregnancy test before you kind of do a whole lot to them, because you have no idea if they're pregnant. So that is a cue that we've analyzed. The female portion of this is important because, of course, of the other situation we just described. She could be pregnant, and you know what goes with that. The unconscious part is like a no-brainer, right? We know that if she's not conscious and we don't have a pulse, then we'd be doing CPR. If she's unconscious and she does have a pulse, then we are just trying to support her in her unconscious state. Okay? Sexual assault, oh my God. Don't worry, you got to know your STDs. So along with sexual assault goes your knowledge of what STDs this patient could have contracted. It's not necessarily your priority, but it is definitely something you have to keep in mind with regards to gonorrhea, chlamydia, trichomoniasis, your syphilis, your HIV, your herpes, your warts, anything like that you have to keep in mind. And like I said, if it's a sexual assault, she could have also gotten pregnant, okay? Now, as we move along here, we have on the second line a Glasgow scale. And I just want to tell you a really easy way to remember your Glasgow scale. If you watch what I write on the board, I teach you to remember E, V, M. So if you can get that close up and you see the EVM, then also you're going to remember what goes with it. 4, 5, 6. Now, the E is I. Did they spontaneously open their eyes when you called their name? The V is verbal. Do they talk without a problem, or what's going on there? The M is motor. When you add all of these up, you get a total of 15. The highest score any patient can get is 15. This Glasgow scale is a Glasgow coma scale, which means it's done at the scene of the accident or the trauma. It's done every single 15 minutes or hour until we get to the point where we're transferring the patient. And in this situation, we're still in the middle of major trauma. So her Glasgow scale is only 6. And of course, we said the highest was 15. Now, you got a long way between 6 and 15. So let's try to educate ourselves on what that's about, right? Well, we always say that stable is 12 to 15. So we're not stable. And then we say that less than 8 equals intubate. How about that? Is that a nice little rhyme for my babies? Less than 8 means intubate because you're not breathing, you're not conscious, because the 8 is the cutoff. And this is where we say with a Glasgow scale of 8 or less, you're in a coma. So she's unconscious, she's got a Glasgow scale of 6, she's in a coma, okay? So that's analyzing our cues. We recognize them, now we analyze them. And the analysis of this patient is that she is of childbearing age, female, she's not conscious, she's just been raped, she could definitely have gotten pregnant from that rape and gotten STDs, and she's in a coma as we speak. Now, if we keep on moving down the road and we continue to analyze what we're seeing in this case study, if we look a little bit further about what we're dealing with, we have a blood pressure of 80/60. Now, many of you have already received my Oh My God packet for free. In that OMG packet was all of the information you need to know about adult vital signs, pediatric vital signs, when to panic, when is it just abnormal. And so if you have my Oh My God packet, and be sure to reach out to me if you don't, because I do give that away for free. And remember how you reach me, okay? Y'all want to know how you reach me? Here you go. 216-410-0936. Y'all need to text the sister girl if you want some holy hookup, okay? I'm just saying. Now, if you've called, or even better, if you emailed me, and let's remember how to email me. You email me at Chelly'S NCLEX PREP @gmail.com. And yeah, when you do that, you too will qualify for a free OMG packet. It's your complete study guide for NCLEX, okay? So do the damn thing, will you please? All right, now moving on. So in my Oh My God packet, on page 7, that's for you players who's looking in the packet right now. On page 7 is all of the who you see first patients, right? Because we're trying to prioritize stuff, and we have a whole list of people who rank as the people you should see first. Included in that are adult vital sign extremes, or out of control or not within normal limits, right? So you probably know already without looking at page 7 of my OMG packet that a blood pressure less than 90/50 is an alarming blood pressure, warrants your immediate attention. And here, sister girl is 80/60. Now don't forget the rule about blood pressure. You don't need both numbers to fit the criteria, just one will do. So if you look at this blood pressure and then you go by, I think it's on page 10, and you remember what I taught you on page 10 in the Oh My God packet, you know that all low blood pressure is shock until you prove it's not. And so we have to look at the fact that she could be definitely suffering with shock already because her blood pressure is so low. Now let's think about some of the shock she could be suffering from. I wouldn't be guessing stupidly on this one, right? You wouldn't say that she's in cardiogenic shock, because cardiogenic shock would require that she had a pre-existing cardiac problem beforehand. You wouldn't say that she's in anaphylactic shock, because it's not like she just got done eating peanuts. You probably would have to guess something along the lines of hypovolemic shock, because her volume of fluid, in this case possibly blood, she may have lost a lot of blood in this traumatic event and accident, and so she basically will have a low blood pressure because volume of fluid controls blood pressure. She's losing blood. Blood is a fluid. She has a low blood pressure. I don't think I would call it septic shock. This event just happened, and septic shock takes a while to build. I hope that helps. Now, she could be in neurogenic shock, but I doubt it. And the only reason I say I doubt it is because this was such a traumatic event. This case study talks about a perforation, which definitely is a way to lose blood. And there's nothing in this case study that leads us to believe that she's a spinal cord injury yet. And with neurogenic shock, you're a spinal cord injury, you're flaccid, and so that would be why you're in shock, but I don't see that here. So we're gonna stick with she might be going through hypovolemic shock. I think that's a good guess. All right, now it reveals, her exam reveals a blunt head trauma. Oh my God, that's important. It's very important, because up here you'll notice in my neuro notes that there's something that says closed head injury. Well, blunt head trauma is a closed head injury. It actually takes priority over open head injury, because if it's a blunt head trauma, that means closed head injury, and if it's a closed head injury, that means that blood cannot escape, and so it's just building and building and building, increasing the pressure in the head. And again, remember what we're doing right now on this next generation NCLEX exam. We've already recognized our cues, now we're analyzing our cues, and we've analyzed the fact that a blunt head trauma is a huge priority because there's a very great risk of high ICP. Now we're going to continue. Unequal breath sounds, OMG. You already know where I'm going with that. You know that you learned in school, like I did, ABCs, right? Airway, breathing, circulation. You did, and I did, but I always teach you a little differently. I make sure you know that that's not what you want to go to the test with. You don't want to go to the test with ABCs, because they do not teach you how to prioritize. What teaches you how to prioritize is behavior changes first, and then we can look at maybe some airway stuff. But honestly, in this situation, her unequal breath sounds are a big deal, but they may or may not be the point of the case study. But since it's in there, we've got to be thebomb.com and analyze it, right? We've got to understand when we say unequal breath sounds that she might have a pneumothorax. She may have, during this traumatic event and this horrible assault, she may have gotten some fractured ribs. Now that may have caused some flail chest, some paradoxical breathing, some uneven breath sounds, that sort of thing. When you hear that language, start thinking do, 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 tension pneumo or pneumothorax from the trauma of this event. And then I want you to start thinking a little bit bigger. I want you to start thinking, what are we gonna do about it? Well, we probably are gonna be starting to think about some chest tubes, okay? But again, that's going too far. Let's just stick with our little analysis. So unequal breath sounds is an airway thing, is an airway issue that needs your attention yesterday. I hope you're with me. Now, unilateral pupil dilation. Well, So on the right side, right or left doesn't matter. Here's what unilateral pupil dilation should be analyzed to mean. It's another word for ipsilateral pupil dilation. It means she has a concussion. So she received some serious blows to her head in one way or another. And so she definitely has a concussion, because that's usually what we see. Now, we're gonna keep moving. Rape victim means you better get your sexual assault nurses in on this so they can do the DNA testing, the STDs screening, the whole thing. She's a thin frame, so you still have to really think about other sources of trauma. It may not be our priority, but she could have broken some bones, right? She's thin, so she could have broken her wrist in attempts to fight back. She could have broken her legs, her arms, anything, depending on what kind of traumatic situation this was, where she was when it occurred. Then she has shredded fingers. Oh my God, this poor thing. And so that means that she fought back. There's great DNA usually under the nails in that case. Now, X-ray and CAT scan, you already know where we're going with this. Test and labs, you and I are gonna work it, okay? X-rays are always done with any kind of trauma to identify the broken bones I just discussed with you. The CT scan, we gotta go a little bit deeper. You know it is the #1 test of choice whenever head trauma is involved, because we're trying to find out if we have a brain bleed. We're trying to find out just how serious this might be. But a CAT scan is also useful in the identification of a stroke. Don't forget I said that. Now, a CAT scan could be with contrast or maybe not. It just depends. In an emergency situation, ain't nobody got time for contrast dyes. But if we do use contrast dyes, you have a couple things you better remember on the test. One of those things you need to remember with contrast dyes is it's very toxic to the kidneys if you don't push fluids afterwards and if you don't identify whether or not there was pre-existing kidney damage. Now, what do I mean by that? Well, what was the BUN and creatinine before we even started this contrast dye? Did you check it for high-risk patients? You should have. So you have to kind of be very wise about that. You also have to know what kind of medications the patient was on prior to the CAT scan with contrast, because metformin is not allowed 48 hours before or 48 hours after a CAT scan, because it can literally cause some acidosis, some kidney failure. It's really serious. Lactic acidosis is nothing to play with. So again, don't forget I told you, no metformin before or after a CAT scan. Now, but this is an emergency. So in an emergency, I doubt that they're using contrast dyes. This woman can't really even function, and so we just need to know right now what's going on. One more thing about a CAT scan, just in case you didn't know, it's a lot of radiation. It's more radiation than an X-ray, and that's why we don't want to use it just willy-nilly. I know that people and nurses and doctors in America we have so much at our fingertips, right? We have a CAT scan machine, like 50,000 of them in every hospital, but let's not get away from the fact that we should only use tests when absolutely necessary, because this is a lot of radiation, and you know what radiation means. It means you could, risk cancer. So log rolling is another thing that you saw in Grey's Anatomy being done with this patient. And I want to make sure that you know with log rolling, you need you need 3 people. 2 of them need to be nurses, 1 on at the head of the patient, and 1 on either side, because 2 on the same side. I messed that up, didn't I? I'll say that again. Log rolling, 3 people, 2 of which must be nurses, 1 at the head of the patient and 2 on the same side of the patient, keeping the patient's body well aligned, and the legs and the hips and the arms and the shoulders and the head must move together when we move the patient. I hope that helps you with log rolling. They kind of like that on certain tests. Now the Zoll monitor, you don't care about that, so let's look at the ventilator. I know you are not really into vents right now. There's not a lot of ventilator questions on this exam, but you just need to understand this patient's unconscious. Of course you need it intubating, and of course she's on a ventilator to support her respiratory system. Now we're off to the OR for brain surgery. Just remember, your responsibility when preparing a patient to go to the OR is a little different with an unconscious patient. It's not like you can ask them anything, but you still need to be aware of the risk of surgery, and the risk of surgery come with 5 big, huge complications. Let's take a look at those complications. I'm going to put the complications in order of deadliness, okay? So the first complication is anesthesia. This is the deadliest complication of any surgery. What kind of complication could we have in anesthesia? Well, we could have malignant hyperthermia. That means that an inhaled anesthetic was used because the patient was given general anesthesia, and when that inhaled anesthetic was used, usually it's succinylcholine. Remember that, sucking on the choline, sucking on the choline. I'm sorry. Stay focused. Succinylcholine is one of the #1 drugs that you would have to remember for malignant hyperthermia. It's deadly. The patient's pulse is going to shoot to 110. Their temperature is going to go all the way to 105 and higher, and they can die. Now, how did they get that? Well, it's genetic, so people don't necessarily even know about it. And what happens, it's the dominant recessive gene, like it's autosomal dominant, which means only one parent has to have it. And how that plays out is, if you know somebody in your family that died in surgery or immediately after surgery, then you are at risk, because that might have been what they died from, malignant hyperthermia, okay? All right, now the second risk, and everybody knows this, is hemorrhage. Now, this is not your first rodeo, and I'm thinking that you got past kindergarten, so this is not going to like shock you that whenever somebody has surgery, they could bleed. And the bleeding is such a big risk. That's the rationale for why we take vital signs every 15 minutes times 4, every half hour times 2. And those vital signs play a role in us understanding whether or not you're hemorrhaging. One of the biggest issues is tachycardia. When you hemorrhage or going into shock, the pulse will start to go up first before the blood pressure goes down. Usually around the loss of 1/3 or so of your blood volume, the pulse is going to be 20 beats higher than the average pulse of the patient before they went in or during their recovery. So that's hemorrhage. Watch the pulse for tachycardia, right? All right, now number 3, because that was 1 and 2, complications of surgery. Number 3 is DVT-PE. What do I mean by that? Well, when you have surgery, you have a very real risk of your platelets clumping together and causing a clot. Now, there's several risk factors that make you at higher risk for developing clots, but one thing I need to tell you about this case study and the fact that she was taken to the OR, thank God she's young, because the older you are, the more clots you get, right? But she's been taken to the OR, and we still have to do our post-op recovery monitoring, and we're looking for DVT-PE, but not in the immediate post-op recovery. We're talking about a few days later. So it's not a big deal right now, but it's a bigger deal later. Now, don't forget the basics, okay? Don't forget that 100% of all pulmonary embolisms were caused by an original deep vein thrombosis. Now they call it something different, although, you know, whatever. I'm old as shit, so I stick with the old and the new. Venous thrombotic embolism or event, okay? VTE, DVT, it all sounds alike to me, okay? Woo! I thought that up just that fast. I'm born to be a rapper. I need to call Dr. Dre. Okay, so whatever. You have a patient with 100% of all PEs starting out as a DVT, and I'm just, for the sake of love, kisses and hugs and handles, I'm just going to give you, because I love you, some risk factors, like a select all risk factors. Woo! For a DVT-PE, here we go. Surgery is number 1. Immobility is number 2. Obesity is number 3. And estrogen is number 4. Smoking is number 5. And believe it or not, your height is number 6. So those are your risk factors. So, you know, again, that was a select all. Now, the 4th complication of any surgery could be pneumonia. Well, now that's a big deal because this pneumonia, again, will not show up right away because infections take a while to grow. So this pneumonia is not going to go and just like pop up in the PACU, right? In the post-anesthesia care unit, in the recovery room. It's not going to be like, wee, I'm pneumonia. No. It's going to grow. And the reason for that pneumonia, and I need you to know this fancy $4 word, is atelectasis. Yes, hunty, yes. Watch. Atelectasis, which means collapse of the alveoli related to someone going through surgery and doing that shallow breathing. You ever wondered why you learned in every single nursing school since Christ left Jerusalem that you're supposed to teach the patient cough and deep breathe? Did I do that good? I'm sorry, that was kind of weird. That was stupid. Okay, whatever. I need you to teach the patient to cough and deep breathe. So here's what's going to happen in recovery. The patient's pulse ox may drop a little bit because they're so sleepy, don't want to wake up. You're the nurse. Actually, you're Nancy Nurse. Let's do Nancy Nurse because we do have a fictional character in my program called Nancy Nurse. Nancy Nurse is the annoying nurse. Here she is. Annie, your surgery's over, honey. I'm gonna need you to take some deep breaths. Come on, honey, wake up. Oh my God, you want to punch her in her throat. You can't because that's assault and battery. But if you really listen to Nancy Nurse, she was telling the patient to take some deep breaths. If the patient takes the deep breaths, guess what, y'all? She just opened her alveoli, she expanded her lungs, and her pulse ox shoots up to God knows what all, literally to the normal 100% we need her to be at. You see, when she's so depressed by all those anesthetics, she's taking shallow breaths and she's allowing her alveoli where the gas exchange occurs to collapse, and that's not cool. And so that's a big basic care and comfort you better know. Post-op patients, cough and deep breathe. You got it. Last complication after surgery can be, and you knew it, infection. And again, this is not going to be in the immediate post-op period. No. Infection takes a while to grow. What's the best way to prevent this? Wash them damn hands. Get you some hand sanitizer. Find some soap, some Bath and Body Works, something. Wash your damn hands. Moving on. This was a case study, okay? Just stay focused. Now, so we are here in our case study. The patient had surgery. Preoperatively, the nurse is aware of 5 deadly complications of any surgery. Anesthesia complications, hemorrhage, DVT, PE, same thing, right? All in one. 100% of all PEs are DVTs. And then for number 4, we have our patient that has the pneumonia or the infection, okay, for 5. Now, moving on. This patient had complications, but she didn't have any of those. Instead, she had a complication from brain surgery, which is why I told you to figure out what kind of case study this is. This is all neuro. So if you're thinking neuro, then you should be thinking everything I taught you about neuro, like high blood pressure, seizures, ICP, headaches, blah, blah, blah. And sure shit, she gets a high ICP. Now, I think you did really good. You stayed focused. You're still here with me. Hopefully you hit the subscribe and the like. And now we're going to move on in our clinical judgment measurement, and we're going to start to prioritize hypothesis and create solutions. Deuces.